So that you should also explain to the relatives also, patient, that yes, it doesn't mean that the patient has worsened. It just means that possibly the support system has changed. Imagine, mind you, we didn't have non-invasive, used to intubate the patients. But these limitations have to be selected again in viral ARDS, where you have seen ARDS only, if you see the Berlin definition, only the mild forms where the PF ratios are between 200 to 300, that was only the initial stages of ARDS where it was considered. But even now in the later stages, now it's not being considered, because the applications even into these COVID ICUs, again, it's again become failure. And in these COVID kind of situations, it becomes very controversial to use it, because it is a aerosol generated procedure. And this paper was published on the 5th of March, where it showed that there is limitations as far as the use of non-invasive ventilation into these COVID patients. Now, as per the WHO, the SARI patients which are there, the clinical management of these patients, again into COVID, as I told you, these COVID patients, they have got severe acute respiratory illness, and these could be elderly patients, they could be asymptomatic patients, these could also be typical with bilateral infiltrates. Only the mild patients, again I'm telling you, mild patients will respond to it. Please do not initiate it on fluoride ARDS, or those patients who have got a PF ratios which are very, very less. So the COVID pneumonia is there. Even in pneumonia, those patients who are severely respiratory distress, those patients who are severely acidotic, those patients who are a pH is less than 7.1, starting NIV is not a good indication. And again, I told you, in cases of severe pneumonia, where in case of respiratory distress or severe respiratory failure, this is not the right choice. So even these are the WHO indications. I won't go into the details of it. So more importantly, in case if you need to supplement them, it's going to help you to improve the oxygenation. And I won't go into the details as far as the oxygen or these are concerned. But more importantly, if you really consider into this, there was another concept of non-invasive which occurred, and that non-invasive concept was with the help of high-flow nasal oxygen. Yes, high-flow nasal oxygen is one new entity which has come up over the last couple of years. It is over a period of time, it is said that this may or will consider to be replacing non-invasive mechanical ventilation. Here what you do is you deliver high-flow nasal oxygen, again started with 40 liters, then 50 liters to 60 liters to maximum of 70 to 80 liters per minute of gas flow. And this because of the high flow of nasal oxygen which is being delivered to the patient. Yes, this delivery will help you to generate certain positive pressure. Mind you, this positive pressure which is generated from high flow nasal oxygen is about 6 centimeters to 6 to maximum about 8 centimeters, but it doesn't generate more of pressure. So you can again use it in cardiogenic pulmonary edemas. You can use high flow nasal oxygen by means of using 2 nasal prongs which are then fitted off to these patients in this similar way. Hello. Yeah, then you can in this similar way. Again, mind you, in COVID, giving high flow nasal oxygen is again an aerosol generated procedure. So again, you need to see that preferably it should be initiated and done into where negative pressure rooms are available. But where we don't have the luxury of negative pressure rooms, yes, definitely where you can use it with full PPE, with a face shield which is there. Now this patient who is there with high flow nasal oxygen, only this is there, this patient can again be put he can be put a face shield. That's not a problem, and that's absolutely okay, because he can also avoid the aerosol dispersal through that is also equally important. Now here again, it is again used only in mild patients, but again, mind you, not for moderate failure, not in patients of severe kind of respiratory failure. Again, there have been limitations as far as the use of non-invasive ventilation in patients of COVID. Their NIV, as per recommendations, it makes no recommendations on use of hypoxemic respiratory failure apart from cardiogenic or in patients of post-operative respiratory failure. But mind you, there have been certain studies which have shown only in mild cases or the early phases, you can consider to use it, but it again has to be on a very high alert that this patient is going to be intubated and have to be put into mechanical ventilation. The monitoring has to be very, very, very severe. Now, the call for intubation, if you see here, why intubation, this is a very diagram which tells you exactly like once you have started on patients of oxygenation, either you start off with masked oxygen with a reservoir bag with 100%. In case it's not there, you have started off with nasal prongs with a high flow nasal oxygen. In case if there is a failure of high flow nasal oxygenation, please do not take the patient on from high flow nasal oxygenation to non-invasive. It's almost like it's like failure. Please then electively intubate the patient and put them onto mechanical ventilation. Only in these mild patients of COVID or mild amount of failures of these patients, that is the time where you can consider non-invasive. But if at the end of 1 hour, in case properly, if you find that there is no difference in the gas exchange, no improvement, please then terminate non-invasive and then move from non-invasive mechanical ventilation to invasive mechanical ventilation. So the intubation, again, I would just start off, though I would not go into the details of these intubations for these. These protocols are available there. Intubation is aerosol generated procedure which is there. So mind you, the initiation, monitoring is very important. Selection of the patient is very important, mainly in patients of COPD or acute cardiogenic pulmonary edemas, where you use a bilevel, or you can use CPAP, and CPAP mainly is for obstructive sleep apnea or for obesity hypoventilation syndrome. Now, the difference between a bilevel and this is most importantly in CPAP, there is a continuous positive airway pressure which is maintained throughout inspiration as well as expiration. That means 8 centimeters of, if you put a CPAP of 8 here, 8 centimeters of pressure is going to be maintained throughout the respiratory cycle of inspiration as well as in expiration. And in bilevel, you put 2 levels of pressure in one respiratory cycle. The patient's inspiration or the IPAP occurs at a typical pressure or a different pressure of say 12 centimeters of water, and the expiration will again occur at a lower centimeter, that is in the same respiratory cycle. The patient breathes at a higher pressure and a lower pressure, and the lower pressure is means is corresponding to the EPAP or equivalent to the PEEP, below which it doesn't collapse, and it helps you to keep the alveolus open and helps you to maintain oxygenation, improve the oxygenation, also drive the fluid out that is there. So these are in short about non-invasive mechanical ventilation.